Tooth extraction is a very common procedure. When we extract a tooth, hardly we think how and when extraction socket is going to heal. In this video, I'm going to tell you the reasons why you should know about the healing process in the extraction socket, and later I will discuss how the socket heals. I will summarize in the end with few very important questions that arise related to this topic. If you are a dental student preparing for competitive exams, or if you're a fresh grad, you will find all or most of your questions answered. If you like this video, please like, share, and subscribe. Now, for all of you who don't know me, I'm Dr. Swati Gupta. I am an Indian trained periodontist and I'm right now a DMD practicing in the US. Without further ado, I'm going to start the video and explain why we need to know about the healing of extraction socket. So, like I said, it's really important to know about healing and why. Very important point is that the ridge and the bone, it undergoes significant alterations after tooth extraction, and that decides the type of reconstruction that you're planning. It could be implants, dentures, or a crown and a bridge. And yes, like we always say, in perio, in oral surgery, when we are doing any procedure, or even in general dentistry, when you're doing anything, when you're treatment planning, you always have to think about the outcome. A procedure will be done. You'll do a root canal, but you always have to think, is that it? After the root canal, am I going to do a crown on this tooth, or am I just going to send the patient after this? So you always have to think ahead. And that is the very important part about treatment planning. Same thing, when you do an extraction, you just do not extract and send the patient home. You always have to think, how am I going to replace this missing area, this missing tooth, the area that's empty? What am I doing there? Because you do not want an unbalanced occlusion. You want a balanced occlusion. And the outcome, how your ridge is healing, will decide what are you planning, right? Like for an implant, you need a good ridge, you need a good ridge height, you need a good ridge width, you need a good amount of bone. That means if you have a patient whose extraction socket is not healed properly, or let's say if we know that after this extraction the bone is not going to be good enough, or probably a lot of bone is lost, then you know that, and the patient is very much insisting on implants, and you know that you'll have to do something like a ridge construction there, a ridge augmentation there, or you'll have to send it, if you're a general dentist, you'll have to send it to a periodontist who can do some grafting before, so that there is good amount of bone present as the patient is interested in implants. Or if you know the patient is interested in dentures, then maybe you are not really concerned much about how your bone is going to be in the end, although it's always ideal to have a good amount of bone present. But definitely, you're not going to send the patient to a periodontist or an oral surgeon to make sure that there is a good amount of bone present because the patient wants dentures. And the same principle applies to crown and bridge. So it's very important to know about healing, and that you are going to be discussing with the patient prior to the extraction in terms of how we are going to rehabilitate it. And now the second point, which is again very important, which is achieving optimal results in aesthetic areas. Why do you need optimal results in aesthetic areas? Again, for implants. Implants are done everywhere now. Everyone is doing implants. So specifically in aesthetic areas, patient is also asking for implants. So you need to understand how to do an atraumatic extraction so that your bone is still there. Or like I said in my first point, if you think that the bone would be less or the bone quality is not great, as we know the bone quality is not very good in an interior maxillary region, you would be considering sending that case to a periodontist if you are not comfortable doing any kind of grafting procedure to augment the bone. Third point, to understand post-extraction complications. Usually, people will ask you, and this is going to actually make sense with my fourth point, which is about patient satisfaction and questions. Patients are often going to ask you, how much time will it take for this healing to happen? when are you going to plan an implant for me, or when I can get dentures here. Some patients will always ask you questions about when can I start smoking. This is kind of a question that was often asked, and I'm still often asked from the patients who smoke, like when can I start smoking, when this will be completely healing, when is the time frame of something bad can happen. So if you do not know how the healing happens, if you are not acquainted with, okay, what is the critical time of the socket to actually be healing or closed, you cannot answer these questions to your patients as to when can you start smoking, right? Or when should you come back so that we can start planning an implant? Or when can we take the primary impressions for your dentures? So many questions that are related to the healing of this extraction socket that you should be knowing, so that you can convince your patients that whatever treatment planning is done is right, and also you can answer their questions. Having stressed the importance of why should I know about healing, or why anyone should know about healing, I'm going to move to the important phases of extraction healing now. Okay, so this is something that I'm not really sure if you've seen this, but normally in any book or in any article, you will find this chart about hemostasis and stages and proliferative. Now, when I'm teaching for iNBDE, or when I'm teaching dental related subjects at board aspirants, one thing that I've commonly noticed is retention. The problem that students face is retention. You will understand everything that I'm talking right now. You will probably make your notes right now, and you will remember whatever I'm saying if I was to quiz you right now. But if I was to ask you whatever I taught today, and I was to ask you all this after 7 days, some students will have an issue because they're not able to retain. When you listen to something, you remember, but when it's gone, when you do not revise that topic for a long period of time, retention is not there and you do not remember. So that is a big question. And what I'm going to do in this video is just not tell you the phases, but I'm going to try to emphasize on certain important things, so that if you are listening to this video for your exams, you will understand those important key questions that can come in your multiple choice questions or your competitive exams or for iNBDE. And if you are a dentist who's watching this video just to understand what you have to tell your patients, I hope this tiny points that I've made can help you remember whatever I talk about. So let's go to the phases. Now, the first phase is hemostasis and coagulation that starts within 24 hours. The important point about this phase is blood clot formation and inflammatory cell migration. Blood clot. Now, whenever there is an injury, wherever there is an injury, be it an injury on your hand, what is the first thing that happens? Blood clot. And we used to read about and learn about bleeding time and clotting time. So you know that anyway, within 24 hours, within few minutes, the clotting is going to start. And we always used to read about the different cells. Platelets are going to come, everything is going to come. I'm going to be talking about that. Let's go to the socket. In the socket, the blood from the vessels start filling the socket. So look at this. I'm going to start explaining with my pointer here. And going to have a pen here. So this is your socket, right? This is your socket, and I love explaining this through histology because you can, what you see, you'll remember. So be just try to understand what I'm trying to say here. So this is your socket, and when a tooth, so the tooth has been extracted, now the blood is going to start filling the socket. We all know that. So the blood starts, and then important questions that comes in the exams is, where is this bleeding coming from mostly? Where is this coming from? That's very important. So all these bleeding, it initially starts from the apex and your lateral walls. It is not happening here in the coronal portion. All that is happening that begins is here in the apex and your lateral walls. Now, what is the significance of knowing where did the bleeding start from? Important point is that since the bleeding started from the apex and the lateral walls, you should be very sure that you nicely clean that area. There should not be anything left, any debris, or you should always irrigate that area, because a fresh bleeding, a fresh stockade, uh, healthy everything is going to start from your apex and from your lateral walls. Okay, so the blood is already started filling up, and then what happens? Platelets are going to come in that area. Platelets are the one that actually form the fibrin network and the forms what is called as coagulum. Okay, so the platelets are going to come in this area, and then you are going to have a coagulum or your clot. And then what happens next? This clot, it contains substances. What's there in that clot is the growth factors. And what are these growth factors doing? Growth factors influence mesenchymal cells. They enhance the activity of your inflammatory cells and also act as a scaffold for addition of cells. Because, and this is, if you understand, this is a normal healing phenomena. Normally, whenever there is an injury, this is what happens. Immediately, platelets will come there, platelet aggregation will happen. Platelets are going to form a fibrin scaffold. On this fibrin scaffold, a scaffold is basically something on which cells start coming in. Consider that as like a cloth or something as a base on which things start coming on. So it's basically a scaffold on which you will start having inflammatory cells, mesenchymal cells, all the growth factors, everything is going to start coming in. And within few days, so this is within 24 hours, all this is happening, right? So basic 24 hours, like one day. And then what happens is fibrinolysis. Whatever the fibrin was formed, then it starts lysing. And if you don't know, here this is PRF. If you see this, I'm not really sure if anyone, I mean, you know it or you might be knowing it, knowing about this. This is PRF. So what is PRF? Platelet-rich fibrin. In periodontics, in oral surgery, this is a very common thing that is used these days when you're thinking about augmentation. PRF, platelet-rich fibrins, these are, like, again, we were talking about how platelets have growth factors. So platelet-rich fibrin, again, is a method where you want a lot of growth factor infusion. So you will use this, and you will they can use it in cases where you need a good amount of soft tissue and a bone formation. It's basically growth factors that is going to act as a steroid, just jumpstart the whole phenomena on a greater degree. You might also think, when fibrin was formed, why did fibrinolysis have to happen? Right? That doesn't kind of make sense, right? You wanted the fibrin, and then the lysis has happened. When the fibrin was formed, that was just a way so that all the cells can come, all the growth factors can come in one place, and you can have the phenomena of the bone that has to form now, because everything is gone, right? The socket is empty. The socket is completely empty. So what is happening? Bleeding is happening. You will have the fibrin coming here, platelets coming here. You have a fibrin clot that is forming. On the fibrin clot, you have growth factors coming, you have cells coming, everything is coming and getting accumulated. And that is your coagulum, that is your clot. Now, that clot is going to go away so that new tissues can form in that area. It has done its basic purpose of making sure that everything is in one place. Now that fibrin is going to lyse. Its fibrinolysis is going to happen, and new tissues are going to form. So this is a very good picture in which you can remember that initially clot formation happens, platelets are coming, bleeding is controlled, and where does the bleeding start from? From your apex and from your lateral walls. Now, what is our second phase? It is a continuation basically of your first phase, where hemostasis and inflammatory cell migration is happening. Which inflammatory cells are coming here? That is neutrophils and macrophages. Now, neutrophils, we understand obviously they are the basic defense cells, right? So they're engulfing the bacteria, macrophages are coming, they're engulfing, and they're cleaning the site. Like we said, fibrinolysis is happening. All the old tissue, everything that got in together, these neutrophils and macrophages are coming and they're cleaning the site so that new cells, new formation can happen. So in this phase, you will see granulation tissue. And if you don't know what's a granulation tissue is basically you have new vessels, you have inflammatory cells and immature fibroblasts. And what does fibroblasts do? Fibroblasts are known for forming connective tissue. So you're having granulation tissue formation. And in this picture, if you see, you have 1 day of healing. The socket is occupied with blood clot, and that is contains large number of erythrocytes. You have this, the portion B, that is your fibrin network. Fibrin is forming, and also you have a lot of cells like erythrocytes in this section. So if you have to remember what all is happening in the first phase, you have a lot of bleeding happening, you have a lot of inflammation happening, a clot is forming, platelets are there, neutrophils are coming, fibrin is formed, then neutrophils, macrophages, fibrinolysis is happening, they're taking away all the old debris, all the old cells, and making way for a new tissue. And also, sometimes if you see your patient comes, if you see the socket after a few days, like 2 to 3 days, you will see something like a whitish slough at the apex or at the base of the socket. Sometimes people get worried that that slough is really basically something like an infection or something. That's not necessarily an infection. Okay, infection is something like an exuding abscess, or it smells bad, like a dry socket, basically, if you're thinking about. But if you just see a whitish slough at the base, which is basically a little bit thicker and it's not like smelling or anything, that is nothing. That is actually the apoptosis of neutrophils are happening. And this basically get removed by macrophages. And then within 2 to 3 days, you will start seeing something different. So again, like I was stressing, that you should be aware of how an extraction socket heals. Why? Because if after 2 to 3 days over a socket, you would see a whitish slough, you should not be worried about it, as long as, like I said, you know how an abscess or an infection looks. Not an abscess, but an infection looks. A whitish slough is basically the cells are dying. When the cells and the old tissue is dying, it becomes whitish at the base, and slowly it's removed by the macrophages, and then you start seeing a clean tissue at the apex. Okay, let's go to another histologic section. So this is at 7 days. Now this portion B is all the vascularized early granulation tissue that is forming in the upper portion. Now, like I remember I was telling you that the bleeding is happening from the lateral vessels and from the apical vessels. So healing progresses from the apex towards the coronal portion. That's really important. That could be a multiple choice question, that could be your iNBDE question, or that's something you should remember as a basic knowledge, that healing happens from the base towards the coronal portion, not the opposite way. So in the apical areas, you will find late granulation tissue if you see from the color, and in the coronal area you'll find early granulation tissue, because that's how the healing is happening, right? When you see a socket, healing doesn't happen like this. The socket immediately doesn't close at the coronal portion and then the healing happens at the base. Healing always progresses from the base towards the coronal portion. And that's what you should always tell the patient. The patient says, oh, my socket is open. It's been 5 days, 6 days, socket is open. They will not see the healing happening on the surface. It's always happening from below, and that's what you have to look for. Okay, now comes your second further inflammatory phase within 48 to 72 hours. That is like 2 to 3 days or maybe 3 to 4 days. Now don't be stuck on the number like, okay, first day inflammation 24 hours, it has to stop. Second time 3 to 4 days, I have to see this. Now this could be 1 to 3 days. The first phase could last for 1 to 2 days actually, and then 3 to 4 days or 3 to 5 days your second phase can last, depending upon a lot of factors. Patient is healthy or no, how was the extraction. But this is the general phenomena. Generally, bleeding will be controlled, platelets will be there, you will see maybe a whitish slug within 2 to 3 days, and then comes your next phase. What is the next phase? fibroplasia and woven bone formation. What is fibroplasia? Rapid deposition of a matrix. What is a matrix? Like we were talking about scaffold. Because in this phase, new vessels are forming. We talked about how fibrinolysis were happening and everything was getting destroyed. That is new phase that was to pave way for the new cells. So angiogenesis, that is new blood vessels. Osteoprogenitor cells, that is osteoblast. These osteoprogenitor cells are going to differentiate into osteoblast, and then these are going to start laying down immature bone, osteoid. And what do you see? So if you see this histologic section, this is 14 days. Now, in the marginal portion, you will see fibroblast-like cells, and in the woven bone formation, here you can see these ones. This is woven bone formation. So the woven bone formation is already started in the apical and the lateral regions of the socket. Again, this could be a multiple choice question, or you should know where the bone formation will start. It starts again in the apical and the lateral region, and then it progresses upwards in your coronal portion. Okay, and um, if you do not know the difference between a woven bone, a trabecular, or a cancellous and a cortical bone, I will be making a new video on that also. But for this video reference, I can tell you that woven bone has no load bearing capacity. Woven bone is basically a temporary bone in this healing, and it will be replaced by a mature bone because this has no load bearing capacity. It is not a permanent mature bone. It's an immature bone. And when do you see this? As early as 2 weeks after tooth extraction. So within 14 days, you will start seeing some kind of bone formation. But where? In the apex, not in the coronal portion again. So maybe it will not be a huge drastic change that a patient would see. And most of the bone tissue in the walls of the socket, that is the bundle bone, is removed. Again, if you're not aware of bundle bone, you're not clear of bundle bone, you can always email me and maybe I can help you understand a little bit about bundle bone. But for this video, I'm not going to go deeper into the bone morphology. Just understand that most of the bone tissue in by the time of 2 weeks is removed. The old bone is gone. Okay, because old bone has to go, right? This is an inflammatory phase, either because of your traumatic extraction, even if it's not if it was an atraumatic extraction, old bone or a little portion of the old bone will be going out, will be resorbed, and then new bone will start forming. Okay, so within 2 to 3 weeks, actually, your old bone is almost getting resorbed. And now the second phase, the last phase is bone remodeling and modeling phase. So what is bone modeling and what is bone remodeling? Bone remodeling is replacement of your woven bone with the lamellar bone or bone marrow. Like I was explaining you that woven bone is only an immature temporary kind of a bone that is formed during the process of bone formation. It has to be replaced with a stronger bone, and that is a lamellar bone. What is bone modeling? It's basically the bone resorption that takes place on the socket walls, leading to a dimensional alteration of the alveolar ridge. If you understand bone morphology, if you understand how the whole bone formation happens, there always has to be some kind of a resorption to happen so that bone formation can happen. And that's what exactly here we're talking about is bone modeling. Bone modeling is bone resorption taking place so that new bone can form, alteration of the alveolar ridge can happen, and remodeling is that bone, the woven bone, getting replaced with the lamellar bone. Now, 2/3 of this modeling process, that is the old bone getting replaced with the new bone, all this occurs in the first 3 months of healing. Let me find my pen here. First 3 months. So first 3 months of healing. It's a very crucial number. That means if you are thinking when to call your patient for an implant, planning, or when should you take the CBCT again, or if you are considering a patient needs dentures, when should I have my patient back, you should understand that the bone modeling, the bone remodeling is happening. So at least for 3 months. And if you think about the whole process of bone formation, the alveolar ridge will keep remodeling for at least 1 year. So changes will keep happening, but doesn't mean that you cannot give dentures to your patient, but you have to tell them that at least for initial 3 to 4 months, you cannot really plan a denture, or at least for initial 3 months, you should not be planning a denture because healing is not complete. You can always talk about immediate dentures which they can wear immediately after extraction. That is the scene for dentures. But when it comes to the question of implants, definitely you will have to give them time. You will have to take a CBCT after 3 to 4 months when the healing is complete. And also, here comes the term corticalization. Corticalization is when a woven bone gets replaced with lamellar bone. It becomes continuous with the cortical plate at the periphery of your edentulous site. This process is corticalization, the cortical plates. So, there's so much discussion of a bone. If you are not understanding what's a woven bone, what's a trabecular, what's a cortical bone, what is corticalization, I would highly encourage you to read from the references that I'm mentioning, or I'll be discussing the bone in my next video, or you can always email maybe some slight things I can always tell you. And again, at board aspirants, that is the whole point of coaching. We try to make you understand the concepts, the basics of everything. You might know what's bone modeling, but if you do not know what a cortical bone is, what a cancellous bone is, you will never be able to retain these terms that I'm mentioning, because you need to understand everything, especially if you're preparing for some competitive exam. And also, if you're not preparing for a competitive exam, but you have too much, you are into research, or you really want to understand, I would encourage you to get in touch, and if you require coaching, we can always help you out. So in this video, I'm going to be, again, like I said, just talk about the basic healing. So in this picture, you can see the first picture is basically where you can see the woven bone after 60 days of healing. And this is after 180 days, that is 6 months. You can see that is largely lamellar bone. So these big ones that you see is basically woven bone, and slowly everything is getting replaced with the lamellar bone. So at 6 months completely you are seeing a good lamellar bone, and within 3 months you will start seeing the transformation from woven to lamellar bone. Okay, and but the whole process, like I said, takes several months to years. So if I have to summarize the healing socket, it might seem so simple, but the days is very important for you to understand, like I said, the treatment planning, what to tell your patient. I'm going to summarize everything here. So your first 24 hours are characterized by formation of blood clot. So when you see blood clot, first 24 hours, 2 to 3 days, you have granulation tissue formation. After 4 to 5 days, the epithelium from the margins of the soft tissue are going to start covering. So you will start having the epithelial migration at the coronal, in the coronal area. So at the bottom, you're having your clot formation, the bleeding, the granulation tissue formation. It's going from base to the top, and slowly, and what's happening at the top is epithelium is starting to cover, but that doesn't mean the bone is forming there. Now, 1 week after extraction, your socket contains what? Granulation tissue and young connective tissue. And like I said, in the apical portions. And also at 1 week, your bundle bone is resorbed. Your old bone is getting resorbed. I'll answer that particular point in the next slide. At 2 weeks, what you have? Immature woven bone in the apical and the lateral parts, like we discussed. After 3 weeks, you will start having signs of mineralization, and epithelium has covered the wound. So after 3 weeks, your epithelium has totally covered the wound. Now, why is this particular point important? Remember, when I was talking initially, I told you that sometimes patient will ask you, when can I smoke? I usually tell my patients to not smoke for at least 2 to 3 weeks. Why? The socket is open. The bleeding is still happening. Bleeding, even if stopped, the clot is there. any kind of heat or any other traumatic event can disturb our clotting process, and you do not want that. So when patients smoke, heat again is a source of disruption for the clotting to have for the clotting that is happening, and clotting is the basis for everything that has to happen, your bone that has to form. So you tell your patient not to smoke for at least 2 to 3 weeks. Now, you do you understand why I said 2 to 3 weeks? Because the epithelium is going to cover the wound in 2 to 3 weeks. That means that's when it will be enclosed, it will be safe from any foreign injury or traumatic injury. 4 weeks, your new woven bone can be seen. After 6 weeks, almost 1.5 months, the bone formation is pronounced and trabeculae of new formed bone can be seen. 8 weeks, which is almost like 2 months, a layer of cortical bone is covering the entrance to the extraction site. So all what you're seeing around 2 months or 3 months is basically immature bone forming, epithelialization is over, you have the bone formation has started to happen, but is it finished? It's not finished. It takes another 3 to 6 months for your mature bone to be covering. And like I said, I'll be answering a little bit about a few questions related to the bundle bone. Very often you will see that, or some people will say, oh, be very gentle with your tooth extractions. Most commonly it's the buccal bone that is lost, and that is again related to this important concept of bundle bone. Now your bundle bone is there on the buccal as well as the lingual bone and buccal bone, both have bundle bone. But prior to tooth extraction, when you have a healthy tooth sitting there, your marginal 1 to 2 millimeter of the crest of the thin buccal bone wall is covered by bundle bone. Only a very little crest of the lingual wall contains bundle bone. So majority of the bundle bone is found on your buccal wall and very less is found on your lingual wall. This bundle bone is a tooth dependent tissue. That means as soon as the tooth is out, this bundle bone is going to start resorbing. And like we were reading from our previous slides, it is lost, starts getting lost within 2 to 3 weeks. You will start losing it. Like here it says, 1 week the bundle bone starts getting resorbed, and 2 weeks you'll have the immature woven bone. So within 1 week, this bundle bone starts going out, and it was a tooth dependent, so the tooth is gone. But where was the bundle bone more? On the buccal wall. Since it was more on the buccal wall, you will see a pronounced resorption on the buccal wall as compared to the lingual or the palatal wall. So your center of the ridge looks like in this picture you can see. So this is the video, this is the picture which shows you healing in 1 week, 2 week, 4 week, and 8 weeks. And you can see how the level of the buccal bone. So this is the buccal bone, how the buccal wall has resorbed as compared to the lingual wall. You can see the resorption happening more in the buccal wall. And from exam point of view, this is a very common question asked, why the buccal bone is lost more? Because buccal wall has more bundle bone, and since the tooth is gone, bundle bone is gone, so the buccal wall resorbs more. Few more questions which I think are very important, and you can try to answer this for yourself first, and let's see if you can match up with the answers. Ridge reduction is more where? In molar or anterior region? I think it's very confusing. Some people find the question confusing. The ridge reduction is more in the molar region, but it is very pronouncedly seen in the anterior region because of the thin ridges. But always ridge reduction is more in the molar region. What is the timing of radiographic bone fill? 3 months, 6 months? So the answer is 3 to 6 months. You will start seeing radiographically the bone fill will be seen in 3 to 6 months. Again, why is this important? Like I said, for your implants planning. You cannot have a patient come in 2 months to see if the bone has formed. Ideally, you should be calling patient at 3 months or after 3 months to see the bone fill. Otherwise, you will not going to see anything in that region. Flap elevation. Flap elevation causes more bone loss than flapless extraction. True or false? Now you might have read a lot. Some people are always, some dentists or some periodontists or some oral surgeon, everyone has a different thought here. Some say, oh, if you do a flapless extraction, that means if the tooth is there, you do not have to really retract the flap or reflect the flap. And they say if you do not do this, then the bone loss is lesser. Actually, this whole point is very controversial. If you see, if you read a lot of literature reviews or systematic reviews, there is no such systematic reviews that says that flapless is better than flap elevation. Most of the studies are coming to a conclusion that when you do a tooth extraction, basically that kind of compensates for any other atraumatic technique that you might have used. So flapless or flap doesn't make much of a difference. Elevators or forceps. What is good for less traumatic extraction? Now, here there is an answer. Studies have suggested that if you use vertical elevators or periotomes, they are very less traumatic as compared to forceps, because with forceps, you're always injuring the bone a lot and you're causing a lot of socket expansion. So they say with periotomes or vertical elevators, you cause less socket expansion and therefore it's less traumatic extraction. But mostly the studies which have said these, they have talked about conical and straight roots only. And my references, like I told you, my references is my book that I wrote on quick review in clinical periodontics. And this article is my favorite. It was written by Origo, and these are the famous periodontal researchers who've done amazing research in periodontology. And this article on alveolar socket healing, I will provide the link in my description. If you're interested, you can always download this article and read it. And again, my another reference was the book by Lindhe. It's a very famous book in periodontology. You can always read it. If you want a concise view, you can read in my book. If you want to read a lot, you can definitely go to Lindhe. And then most of my questions were answered from articles and systematic reviews. I hope you like this video. If you liked it, please like, share, and subscribe. And again, if you have any questions regarding coaching, you can always email me. If you have any questions regarding the particular topic in this video, put it in the comment section and I'll be happy to help you. Until next time, you have a great time.